So today I'm going to talk about a very common topic, that is coughing and cold. That is cough itself as a symptom, sneezing itself, that is another symptom in children who come very often with coughing and sneezing. So initially, a baby who comes with coughing and sneezing, will you give a antihistaminic and send the baby off and see the next patient? You should not. You should not. You should give sufficient time to that baby. Why? Because we know in our country, or not only in our country, all over the world, allergy is a very important component of sneezing and coughing. Allergy. And if you take the history of the mother or the father, anybody in the family, that when the room is dusted, does anybody sneeze? Does anybody sneeze in the family? Often the mothers will say, yesterday I sneezed for 5 times when I woke up in the morning. They will say it. Or maybe my other child, the elder say, he has a bit of this problem. His nose is always running, he's always sneezing. Some problem with his nose, it occurs continuously. So this allergic component you should always look for. Not only food allergy, you should ask about shellfish, eggs. Eggs is a very important thing. The white of the egg, whether it gives allergy, the yellow of the egg, whether it gives allergy, whether prawns, shellfish, these give allergy, whether the baby's house is near a very busy road where a lot of traffic is going and there's a lot of smoke and pollution. Is the baby having problem when you take the baby to the balcony? Or maybe when the baby is inside the room, the baby is better. You should ask each and everything of this. In addition to this, there is some wild flowers and wild plants like parthenium. You have heard about parthenium. Some flowers, like we in Bengali, we say kadam. I don't know in English what you say. It's kadam gach. If it is present near your house, you will get sneezing. Absolutely sure. Sure and certain. You have to cut the tree and that sneezing is gone. Myself, I suffered. I used to stay in Darjeeling for my first posting after my MBBS. I had finished my DCH and I was doing my MD there. My husband was posted in Darjeeling and I used to go into Darjeeling off and on when on my breaks. What used to happen, NJP is on a flat land, Shiliguri. I used to alight from the train in NJP and then used to get up in a car and go to Darjeeling. As soon as I crossed the trees of Shukna forest, there are Shukna forests, two sides. My nose used to say, no, don't go, don't go. This used to start blowing very badly and I used to get a black tip of the nose by the time I reached Darjeeling. Or by the time I reached Kalimpong already. Black nose, black. Because I used to continuously rub it with the hanky. Continuously rub, it's going on watering, rubbing. And by the time I go to Darjeeling, I had to use inhalers. Inhalers were available then. Initially, when I was doing my medical, that time inhalers were not available. And I used to have my cough. I had a tonsillectomy very early. Adenoids and tonsils are the first line of protection in every child. So don't send them to a ENT specialist when the child is often suffering from coughs and colds because they are sure and certain to get their tonsils out. Tonsils are the first protection of the baby. And the spleen is the next. In thalassaemic babies, we often see the spleen being taken out for cure, but it is never a cure. You have to give penicillin till 25 years of age. You have to give several vaccines for pneumococcus, H. influenzae B, etc., etc. So, I had a tonsillectomy done in Calcutta Medical College. And my doctors told me, ENT doctors told me, now you can have lots of ice cream, which you were refused to before. But what happened is, my nasal allergy went to my bronchus. Initially, it was only nasal and 101 tests, Mantu tests, this, that were done for my illness, sickness throughout my childhood. But nothing used to come out, nothing would come positive. initially, but my parents were very insistent, persistent on having my tonsils being, because they were often touching each other. So they got it done. And that is what a beautiful gain I got from that, from my tonsillectomy. That is, it went down to the bronchus. And I started having bronchial asthma. But my bronchial asthma was very mild. It was mainly to cold temperature. Now that I bathe in warm water, or I don't have ice creams, or I don't have any sweets from the refrigerator, any cold drinks from the refrigerator, before keeping it in the warmth for some time, I am controlled. So you have to control your disease. Control. And what is your controller? It is in children, in small children, it is budesonide. And in bigger children, you just add LABA, long-acting beta agonist. That is, a 6-year-old or above needs LABA in addition to budesonide for their control. What are controllers and what are relievers? Relievers are beta agonists, which is short-acting beta agonist. That is either levolin or asthalin. What is the disadvantage of using levolin or asthalin? The beta receptors, there are beta receptors in the lungs which these beta agonists act on. And if you use too much of these beta agonists, what will happen when there's an emergency? If the baby is admitted in the hospital, that those beta agonists will not work. You are resistant to it. But instead, a long-acting beta agonist often does not do this harm. It does not act mainly on the beta receptors. So the beta receptors are kept for treatment, acute management of bronchial asthma. In my life, I have seen a very bad incident when I was in Bisiroy Children's Hospital. Our RMO, Otonu Jana, he had his sister's brother suffering from bronchial asthma. And there was an acute exacerbation. At that time, inhalers were present, but we did not know that LABA had to be added to budesonide after 6 years of age. That baby died in front of us in the OT after anesthetic bags were used to keep the lungs open. Died in front of us, 14-year-old. That was also in the 90s. Then Otonu is now a neonatologist. He went to Australia, he learned neonatology, and he now works in Fortis Hospital. But the problem is we lost that child. Now, after 6 years, we just change, we add LABA in addition to budesonide. What is a beta agonist? Beta agonist decreases the mucosal spasm and the bronchospasm. But the relievers, that is the controllers, the steroids, that is the budesonide, what it does is it keeps the airway open. Keeps the airway open. That is, it is like a broom washing away everything. Washing away everything and keeping the airway large. So the oxygen can enter into the last bit of the lung and the VQ exchange can occur. Hypoxia. So this is the difference between young children and older children. And this is how you treat bronchial asthma. And you have to control it. Like hypertension and diabetes is controlled, you have to control bronchial asthma. Some are early wheezers, that will go away by 3 years. Some are late middle toddlers who get after 3 years they get their wheezing. Late wheezers, they might be relieved after 6 years of age. But it may recur in adolescence. Don't forget. It may recur in adolescence. Because adolescence is a time when the demand of the body increases too much. That is, the baby is increasing by 9 to 10 centimeter every year. And if the calories are not enough, you will get several diseases, allergy, this, that, many things, tuberculosis. Now we will speak about acute bronchiolitis. This is a disease which is caused by a virus, respiratory syncytial virus. It occurs by 1 year of age. It may be 2 to 3 months to 1 year, or maybe later also. But it is a self-limiting disease. What our teachers is to teach us is it is a self-limiting disease. But what we are finding now is that this acute bronchiolitis can persist for days. like 10 to 12 days, 13 days, 14 days, the baby might need CPAP and ventilation. It is no longer limited to the, I can tell you the name of my teacher. He has passed away, Dr. Talukdar. He was from the army in NRS Medical College. He used to say, in bronchiolitis, don't admit the patient. You just tell the patient to be propped up. You take the atmospheric oxygen, use a nasal drop, keep the nasal passage clear, and after 3 days, when you're brushing, just peep over the balcony to see whether that neighbor's child is okay. But it is no longer so. Nowadays, acute bronchiolitis, we admit. It has changed. We admit. It may be self-limiting because it is a viral disease, but it has very sinister complications. We need the ventilator. We need CPAP. We need oxygen. We need the oxygen hood, or we need the nasal prongs, or we need oxygen in some form in addition to atmospheric 21% oxygen. We need 40, 60, 80, or maybe high flow oxygen also. So that is the sinister complication of bronchiolitis now. It is no longer that easy that you just peep over while brushing, you peep over your balcony and you see whether the parents are okay. It is no longer that. It has changed. So this is acute bronchiolitis. You have to keep the baby propped up. You have to use oxygen accordingly. And you try to admit as soon as possible. Because you also do not know, the doctor does not know, or the parents do not know which baby will need ventilation and which baby will not. 72 hours or maybe another day after that, you watch for 3 or 4 days. If it has subsided, you discharge. If it has not, you do the needful. So this is bronchiolitis. Acute bronchiolitis may be the first attack of wheezing. You think that it is respiratory syncytial virus. There is no way to see the respiratory syncytial virus. In the microscope, we think it is chest retractions. The chest is retracting. There is tachypnea, more than 50 per minute. Tachypnea. The heart, the lower chest is grunt and the respiratory grunt is there of the baby. What is respiratory grunt? Tell me. Do you know respiratory grunt? Have you ever heard? What is respiratory grunt? It is a part of assessing a newborn or a bigger baby. Grunt is the baby is trying to close the glottis and increase the end volume. End volume is the volume which is traversing the lungs. It is closing the glottis, that is the vocal cords, and increasing this part. This part is being increased for getting more VQ exchange. That is called respiratory grunt. That occurs more in stridor. Stridor, it occurs more, and that is relieved by dexamethasone. Dexamethasone, nowadays you can, one single dose used to relieve it earlier. Now you need it 12-hourly, about 2 to 3 days stridor. Stridor is laryngotracheobronchitis. This whole part is inflamed. So that is stridor. Laryngotracheobronchitis. I told you bronchiolitis. I told you early wheeze. And I told you late wheeze. I told you adolescent, what they need after 6 years of age. LABA and this budesonide. And what is reliever and what is a controller. I told you the difference. And you have to control wheeze. That is, a child in school, a school-going child, should grow up normally. The parents should be told not to discuss this in front of the child. That the child has, like a 6-year-old can be diagnosed by spirometry. There is also a device called a spirometry, where the first breath, how much of oxygen you are breathing in the first breath, that can be measured. And you can predict how tiny or small lungs have become or how big your lung is. You can predict. But you should not discuss all this in front of your child. It makes your child handicapped mentally. He should not. He should be told, you should take part in all sports of your school. You just take 2 puffs of your 4-accord food, that is the LABA and the budesonide, before you go into the fields. That is all. 2 puffs. Even a swimmer, I myself, I go to the pool, I take 2 puffs of laba and budesonide and I go to the pool. I can go further. I can go further because my lungs work better. You just do that. That is all. That is enough. And normally, when a child gets an acute exacerbation, you have to give it for 3 months, twice daily. Once before school. If the school is at 10, you give around 8 a.m. And one when the child comes back from school, that is around 8 p.m. And each time before giving the MDI, that is the meter dose inhaler, you have to shake it, number one. Number two is you should prime the spacer, that is the xerostat spacer. Before using it on the baby, you should prime it with 3 or 4 puffs of that laba and budesonide. And after using it once, you should wait for 1 minute before giving the second puff. So this is the xerostat spacer. I'm showing it to you, demonstrating. I need it very less, but I need it. I use it only in the morning and the evening. You can attach both the parts. There are 2 slots where you introduce it and you fix it. After fixing, this is the MDI. This is the MDI. It has a canister. This is the canister and this is the propellant. So you fix it to that and you open this and you shake it. You need to shake it 3 or 4 times because the propellant and the medicine has to mix together. This has a very minute amount of the LABA and the beta agonist, and most of it is propellant. So you need to shake it very nicely, and then when you are breathing in or out, you take deep breaths. Like you attach it here. Before using it on the patient, you have to press it 4 times. This is the way you prime the instrument with the drug before applying it on the patient. In case of a baby, you will need a mask attached to this part. So the mask will cover the nose and the mouth in a under 6-year-old. And above a 6-year-old, you can take, I will show you the breaths. So you take deep breaths. When you are deep breathing, at that time itself, you decide that you are going to attach the xerostat spacer. One dose has been used. And if the medicine formed a smoke outside, that means you have to repeat the dose. It has been wasted. This you have to demonstrate on the first day that you meet the baby, the wheezer. First day with the mask. And you have to demonstrate it. আমরা বাংলায় বলি বিড়ালকে প্রথম রাত্রেই মারতে হয় সেই রকম you have to spend about 1 hour for explaining this. Not only this, using warm water during bathing throughout the year, you not having the refrigerator food, not having the refrigerator cold drinks. The babies, small babies, they love that Coke. They love that Coke. You don't know how much of Coke they consume. So that has to be made warm outside for 5 to 10 minutes. It becomes the normal room temperature. Then you give it to the baby. Similarly, before you take any sports, you take 2 puffs of this and you go into the sports. Similarly, acute exacerbations can be treated. Nebulization is no longer used. Nebulization has gone into obsolete phase from the COVID time because the sisters were nebulizing all the patients without sterilizing it. So I was in Sagardatta Hospital. I saw it. I told them, stop nebulization. Use your spacer and your MDIs. So how do we do it in spacer and MDI? We use it 2 puffs after every 20 minutes. Say you give one puff, you shake the MDI, metered dose inhaler, you attach it to the zero stat spacer. For under 5 or under 6 years, you use the baby mask in addition, that is covering the nose and the mouth. And for above 6 years, you can give, you can exclude that mask. The baby can breathe in and out normally. So you, once the baby breathes in, when the baby is breathing out, you attach the spacer, and then you take in the, you immediately, the parent pushes the MDI and you get the medicine, and then 5 or 6 breaths, like say not even 30 or 40 you count in case of smaller children, and in bigger children it is only 6 or 8 deep breaths. After that, you wait for 1 minute and give another dose of this LABA and budesonide. After these 2 puffs, you wait for 20 minutes and you give another 2 puffs in an acute exacerbation. These 2 puffs can be increased to 4 to 6 puffs, each divided by 1 minute gap. 4 to 6 puffs in gaps of 20 minutes. It can be given 3 times also at gaps of 20 minutes in the first 1 hour, in the morning and in the evening for first 2 to 3 days. 2 to 3 times 4 puffs, 4, 4, 4, that is 12 puffs. 6, 6, 6, that is 18 puffs. 18 puffs in the morning, 18 puffs in the evening initially for the first 2 to 3 days. Then the acute exacerbation will decrease. You can come down. You can come down from 6 to 4, 4 to 3, 3 to 2, 2, 3 times in 6 puffs in the morning, 6 puffs in the evening, and gradually come down to 2 puffs in the morning, 2 puffs in the evening, and continue it for 3 months. And every month you should check up with your pediatrician. Either if spirometer is available, you can measure it, and if for a more than 6-year-old, for a less than 6-year-old, you see it with the height, and you come to your pediatrician and you measure it. So this is the way you measure. So this is a right-sided pleural effusion in a systemic lupus erythematosus in a 12-year-old girl. So you can see over here, what can you see? The soft tissue outside the bony cage is normal. The bony cage is also normal. But you can see the straightening of the ribs of both sides. Why is it so? Because so much of the lungs is jeopardized. Once the lungs is jeopardized, so much pleural effusion, that is between the parietal pleura and the visceral pleura, there's so much of collection. The other side of the lung, compensatory hypertrophy of the other side of, there is increased aeration of this left lung to compensate for the hypoxia which is occurring by this small part of the right lung. You can see the straightening of the ribs. You can count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Normally it is only 7 or 8. That is the diaphragm. This is the left dome of the diaphragm. This has been compressed down because of this compensatory hypertrophy of this lung, left lung. And diaphragm has been pushed down because of this pleural effusion. And you can see the costophrenic angle. There is no costophrenic angle. You can see the left costophrenic angle. That is the diaphragm, and the cardiac silhouette is seen over here. Over here also you can see the costophrenic angle. But over here you neither can see the costophrenic angle nor the cardiophrenic angle. Both are obliterated, and there is a fluid level at the almost at the level of the 1, 2, 3, 4, 5, 6, 6th rib. So this is pleural effusion. This is another USG showing the different ultrasonogram of the chest, the CT scan and ultrasonogram. CT scan and ultrasonogram, what is it showing? It is showing the compressed and atelectatic lung. The lung has been compressed over here. This is the lung border. This is the lung margin. It can be seen over here. It is compressed. This is the amount of aerated lung, and this is the fluid. This is the aerated lung on the right side, and this is the aerated lung in the left side. Over here, a pigtail catheter has been inserted, resulting in re-expansion. This one. a pigtail catheter. This is the pigtail catheter which has been reinstituted to drain the pleural effusion, and the lung has expanded. This pigtail catheter. This is one, and the other one I wanted to show was this one, purulent pleurisy or empyema. This is showing that what I told you, that bread and butter type of pleurisy, where the child will prefer one side to which side the fluid is. Supposing the empyema and the consolidation is on the right, then the baby will prefer to lie on the right side or the left side. This is that sort. Empyema and pneumonia in a teenager. Chest radiograph shows opacification of the left thorax. This is the collapsed lung. The arrows are showing the collapsed lung, which you can see by CT. Over here, similarly, you can see the pneumonic lung in this diagram. This is behind the cardiac silhouette, but if you do a CT, you can see it behind the lung. Pneumonia and parapneumonic effusion. This is the pneumonia, and this is the parapneumonic effusion. In a 4-year-old, opacification of the right thorax as a result of large pleural effusion. Thoracic CT shows a large right-sided pleural effusion surrounding the compressing the consolidated right lung. এই লাংটাকে compress করেছে, আর এইদিকে ট্রেকিয়াটা bend করে গেছে. Trachea has gone to the right. So there are certain comorbidities which has also to be looked at, like allergic rhinitis and mastoiditis and sinusitis. Frontal sinuses develop by 7 years of age. So before 7 years, a child will not have his frontal sinus, and bitemporal tenderness is seen in frontal sinusitis in a 7+ child, not before that. Similarly, mastoiditis is another tenderness on the mastoids, that is behind the ear. On the mastoids, tenderness is seen, and along with that, nasal stuffiness, that is, you tell the patient to breathe with one nose closed, there will be a stuffiness, that is congestion. You look at the nasal mucosa, it is also inflamed. So allergic rhinitis, you have to treat with fluticasone, that is the drug of choice, preferably furoate, not propionate. Furoate is the drug of choice, and it works better than propionate. This is one comorbidity. And another comorbidity I've already talked about, cystic fibrosis, clubbing, pallor, and so I'm not repeating it here. So there is another one, pneumonia. Exactly, just now we have a baby in GIMS, Jagannath Gupta, where I'm working now. A 9-month-old year or 7-month-old year baby was suffering from fever for 9 or 10 days. 9 or 10 days. The baby was given a myriad of antibiotics. What happened is, she developed, her chest x-ray showed a consolidation at the lower base of her left lung initially, first x-ray. That is in June. Later in June, that increased to a massive pleural effusion covering up till her second rib. Huge pleural effusion. Now, usually infective cause, that is pyogenic cause, causes empyema, that is thick pus. And that empyema does not spread up to the clavicles. That will have local tenderness in the area where the pus has formed, that is in the mid-axillary line or the posterior axillary line. If you tap, you will get thick pus. But the pus which was drawn initially, 40 ml, it did not show that thick pus, or ADA was not high. ADA is a parameter for diagnosing tuberculosis. But in all reports, we always say clinically correlate with the patient. You will see in all your blood, urine, all reports, this word is written at the bottom of the paper. Clinically correlate. So it was not clinically correlated. Now, after 10 days, that has decreased. That pleural effusion has decreased. She has developed a new lesion on the left side. And there is a lymph node showing in the tracheobronchial angle. That is, the trachea goes and it bifurcates into two bronchus. Tracheobronchial angle, that is the favorite site of tubercular lymph nodes. They, over there, the left lymph node was not there initially in the first X-ray in June. The left-sided lymph node is showing now, and that consolidation is also showing now. The trachea is no longer shifted to the right, trachea has come to the middle. That is, it is a collapse. It is drawing it towards its side. Collapse consolidation. So it is most probably tuberculosis. ATD and steroids are going to be started today. It's a chronic disease. It is not an acute pneumonia. Because we treated the baby with myriads of antibiotics. I told you, they love antibiotics, West Bengal. All sorts of antibiotics that are available in the market they gave. But the child did not improve. Child was ventilated. Child is now out of the ventilator. Child is out of that IV drip. Child is having oral feeds. But the child is still sick, tachypneic. Why is the child tachypneic? Because left-sided. Another lymph node is pressing on a bronchus and it has formed a consolidation. This is one, and the other one is foreign body, which I told you. I will tell you one story. One boy, I was sitting in Ritik at that time, Moulali. One boy came from Malda. His total white cell count was 50,000. 50,000. He had shown a lot of doctors in Malda. All doctors had been shown and nothing has been done. I did a chest x-ray. That chest x-ray was suggestive. Then a bronchoscopy was done, and a bronchoscopy brought out a seed of a fruit, which the baby had inhaled during having the fruit, and it had lodged. It was a foreign body and it was causing this high WBC count, because whenever the bronchus is blocked, peripheral bronchial path, that gets infected secondarily with secondary bacterial organisms, and the poly and the neutrophils, they run to that site and they form an inflammatory focus. In case of tuberculosis, it is the center becomes caseated, it forms necrosis and it forms a lymph node, which it has formed already in this child, and the mother is the source. We are getting a CBNAT done for her sputum. If that comes positive, she is the sputum positive mother who gave the tuberculosis to the child, most probably. We are getting that CBNAT done today also. So this diagram is showing a pleural effusion in case of a systemic lupus erythematosus. This is a serous collection which has occurred in systemic lupus. It's a collagen disorder. There are 11 systems involved, and out of that 4 systems, if they are positive, it is a systemic lupus. It is usually anti-nuclear factor positive, and that is one type of pleural effusion. Similarly, we can get in both primary and post-primary tuberculosis, we can get pleural effusions. Fibrinous pleurisy causes pain chest, and the baby usually prefers to lie on that side because the pleura are opposed on that side. And the history is that the mother will say that my child is suffering from fever and preferring to lie on the right side or the left side, whatever it is. Initially, it is fibrinous, bread and butter type that is sticking to each other, and later it becomes a huge collection. Usually, in case of empyema, where there is thick pus, usually you do not get, you are not relieved from that pain. That pain will persist. It will be local. It will be limited to 2 or 3 intercostal spaces. It will be just above the consolidation where it has occurred. That is the pneumonia. The pneumonia may be tubercular, may be non-tubercular. So non-tubercular are with Klebsiella pneumoniae, E. coli, etc., all sorts of organisms. Pneumococcal infection we get more in adults. Pneumococcal vaccine is now available, and the baby is getting pneumococcal vaccine right from 1.5 months of age. 1.5, 2.5, 3.5. Then they are getting it again at 15 months. So pneumococcus does not occur now so much. They are protected against pneumococcus by the government of India. So we do not get pneumococcal. That is usually limited to one lobe. It is limited to one lobe, and pneumococcal pneumonia is less frequent now. So Klebsiella, E. coli and other causes, they can occur. And now there's another VAP, ventilator associated pneumonia. Those babies who are being ventilated suffer from ventilator associated pneumonia. That is, ventilators are being used in many babies, and sterility of the make the tube sterile, but it needs a lot of hassle, and the sisters are often not ready to do all that hassle. So one baby gives to another baby. You VAP, we call it VAP. So how do you differentiate between VAP and pneumonia, ordinary pneumonia or tuberculosis? Like this baby was ventilated. Do you think that baby suffered from VAP or from tuberculosis? What we said was that baby had, initially it was a small consolidation, that is a small pneumonia at the lower end of the right bronchus, and it increased, and now the left bronchus is also affected. Left bronchus is also affected, and the left side also you can see a lymph node, that is a tracheobronchial lymph node. So this is a systemic lupus I told you. Similarly, you can, over here you can see in a AIDS and Mycobacterium avium intracellularly, that is HIV in the 80s, I think, in the late 80s and 90s in USA, most babies in the USA hospitals were admitted with HIV and tuberculosis, because HIV and tuberculosis go hand in hand. They both help. Inhibit each other. Inhibit each other is tuberculosis will flare, HIV will also flare. Both are multisystemic diseases. So you will get HIV and tuberculosis, and many died during that time because all the drugs were not available then. Second line ATD was not available then. Second line ATD came in the late 90s. So primary tuberculosis was cured, but after that second line ATD, resistant to INH and rifampicin was not available. So this is that picture, and over here it's showing AIDS and Mycobacterium avium or intracellularly. This has a similarity with tuberculosis. That is, it is showing, the arrows are showing the atelectatic left lung that I told you just now. The left lung, one node was showing I told them to concentrate on that node and the left-sided consolidation. You see it in the USG. You see it in the USG and you see it in the X-ray. But you have to take several views. Several views are required. Then you can diagnose it non-invasively. You don't need to introduce a needle into the lungs. This is one. This picture you can see. And this is empyema. This is showing empyema. And pneumothorax I did not teach. This is a hydropneumothorax. Loculated hydropneumothorax. What happens? How does it complicate pneumonia in a 14-year-old? What has happened here is the thoracic CT can show the level of the loculated hydropneumothorax. What has happened is you have introduced air during tapping the fluid. When you are tapping the fluid, if you're not cautious enough, if you don't clamp your tube with the arrow, then what happens is you introduce air into the pleural cavity. And that fluid has a horizontal level, that will create that hydropneumothorax. It is created by the doctor, not by the patient. If you do a lateral view, you can see that has complicated the 14-year-old's tapping. This is one picture showing it. You will see it. Hydropneumothorax. My father, he was a 60-year-old when he suffered from a pneumothorax. He was admitted, I was in Darjeeling, and he was admitted in a nursing home in Lake Town. The doctor, the general medicine doctor consultant, he diagnosed it as hydropneumothorax. It had a straight level. Usually, they don't have a straight level. I was a bit hesitant. I did not think that it was a hydropneumothorax. I thought that that was a consolidation. So I took the X-ray. I almost stole the X-ray and I took it to my teacher in NRS. He said, I can say his name very proudly. His name is Abuni Rai Chaudhuri, and he diagnosed it as a consolidation. He told me, you hijack your father from that nursing home and bring him and drop him into the NRS. I was absolutely surprised. NRS Medical College of all places. You can save him only if you bring him there. True, my father survived after 1 month. He had no pulse in his left radial artery. Why do you know? There were lymph nodes, axillary lymph nodes. My mother was suffering from lymph node tuberculosis earlier than that. Both of them, I left them here for 1 year ATD. Both of them, one emaciated after a pneumonia, and the doctor, Abunirai Chaudhary, told my husband that he will not survive, but he survived with a lot of hassles. So this happens.